All right. Well, thank you so much for joining me today, Dr. Anjali Malik. You are a board-certified breast imaging radiologist in the DC area, correct?
Correct. Yep.
Right. And from what I read on your webpage, do you service 7 different offices in that area?
We do, and we're expanding. So we are in the
Perfect.
DC Metroplex, so that's DC, Maryland, Virginia. So a wide area in the Mid-Atlantic.
Excellent. 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 And so this is October Breast Cancer Awareness Month. So I was like, I'm gonna check in with Dr. Malik. We've done a conversation before, but it's been a minute. But
Yes.
basically what I wanted to do today is just go over the basics of breast cancer and then also rapid fire facts and myths, and you're gonna answer those for us. So let's just hit it. I'm just gonna start with some of the stats that we know so far. 1 in 8 females in the US alone will be diagnosed with breast cancer in their lifetime. That's 1 in 8. Yep. It's the most common cancer in American females, except for skin cancer. And it's estimated that in 2021, about 30% of all new female cancer diagnoses will be breast cancer. That's 1/3. There are over almost 4 million breast cancer survivors in the US. And then on average, every 2 minutes, a female is diagnosed with breast cancer in the US. That's pretty incredible. Pretty incredible.
It is. It is. And, you know, to give some reference to those startling statistics. So, you know, it was previously the number 2 breast cancer or number 2 cancer to lung cancer in women. And in 2020, it surpassed lung cancer and became the number 1. And of course, part of that is going to be related to the fact that we are getting better and better with screening, our ability to diagnose and access to screening, which means those women who have breast cancer. But also we know that there are environmental factors that are playing a part in that we can talk about. But the other thing I want to mention is that the pandemic has, of course, exacerbated the disparities in healthcare and also access to screening. So we know that there will be an excess of 3,000 extra deaths related to delays in breast cancer diagnosis and treatment. So that's going
to be in 2 parts. That's going to be first part is because people are not going to do what's considered elective things because of the pandemic, and I get it. But then the other part is, and I've seen this within my own family, if something does need to be done, there's such a backlog that it's taking longer to get in, right?
Absolutely. Absolutely. I mean, we've been working full throttle since March, I would say. We've been here since March of 2020. You know, we did have decreased services for that initial, you know, sort of the quarantine that everyone faced. And then after that, we've been here, but unfortunately, our patients didn't necessarily come back in waves. They understandably waited for the vaccine or for numbers to decrease to what they felt comfortable with. And so we have had October to December levels of volume since March. You know, and we're happy that women are coming back, but it does, like you said, mean delays. There are the same number of us and more of them. So.
Yeah. No, I know, I get it. And, you know, and I just want to start off this conversation. And this is because I've seen it recently in my own family. You know, we can talk, we will talk about who's recommended to get a mammogram, okay, and when to start. But what is the hesitancy? I've had family members who just put it off and put it off and put it off. And they've got coverage. It's not like they don't have, you know, not able to get it. Is it fear? Is it the fear of the unknown? I don't think it's the actual mammogram itself. I don't think that's enough to keep someone from going and getting it, although it's not the most pleasant thing to experience.
Sure.
You've been doing this. What do you think is the biggest hesitation for people to make that first step and do it? And what can you say to them to put their mind more at ease and say, you know what, you just need to do it?
So there are many barriers to entry. I think if I had to pick one, it would be the exam itself. I think women are afraid of the pain. I mean, that's just what I hear the most. They're worried about the pain. To which I say there are multiple ways that we can combat that. Number 1, do your exam mid-cycle in the middle of your 28-day menstrual cycle, for example. So day 1 is your first day of bleeding. Day 28 is the last day before the first day of your next cycle. Do it in the middle. You'll have the least amount of pain because there's the least amount of hormones that are fluctuating and affecting the breast tissue. You can take something like Tylenol or Advil if you want to, if that's going to make you feel better before your mammogram. And you can talk to your technologist about ways to make it more comfortable. There are some mammogram compression paddles where the standard one is flat, and of course our breast is round. So there are some that are curved. It is a vendor specific, so I'm not gonna, I don't want to get specific on that, but you just ask your facility if that's something that they have available that can decrease any associated discomfort from a mammogram. Other barriers to entry. So, we talked about, you mentioned coverage. There is coverage for mammograms. It's required as part of the ACA. So we have coverage for mammograms, for screening mammograms. That should hopefully never be a reason that a woman is not obtaining a mammogram. But access is going to be one. So, whether it's just making that doctor's appointment and going to get that screening, or whether it's, living in rural and remote areas. For example, yesterday being Indigenous Peoples Day, I did a whole post on how there's limited access in those regions. So there are mobile mammography units to try to decrease that barrier to entry. And then just fear and anxiety and confusion. There were so many confusions about guidelines. You hear so many stories, either way, about the false positives or about the false negatives. And so, we just want women to know that annual mammogram starting at 40 for average risk women, that's the 1 in 8, that's the average risk, does save the most lives. It decreases mortality by 40%. Breast cancer can be a survivable and curable disease when caught early. And, we're just here working our hardest to detect, diagnose, and save lives.
Yes. Okay, so let's jump into some of the risk factors. There are risk factors that we have no control over, and there's risk factors that we might have some control over. So let's first talk about the risk factors that we really have no control over. What would that include?
So our top 2 risk factors for the development of breast cancer are being female and aging. And even though we can change our gender these days, it's any form of ever having been a female if you've had estrogen on board. So if you're a cisgender woman, if you are a transgender woman and on hormones, or if you are a transgender man who transitioned after puberty. If you've ever had estrogen and progesterone in your body, you are at risk for the development of breast cancer. Aging, no amount of Botox is going to decrease your risk for age-related breast cancer. We hear most often about premenopausal breast cancers because those are the women who are sharing their stories most often, because they are outliers. But the average age for the development of breast cancer is typically in our 60s. It fluctuates between 62 and 65 as the average age. So our risk actually increases. You mentioned 1 in 8 over the course of a lifetime. And that risk does increase with age. Other non-modifiable risk factors, of course, family history of premenopausal breast cancer, a known genetic mutation, a history of male breast cancer, and there are certain races and ethnicities who are more highly predisposed to this. So the Ashkenazi Jewish population and the Black population. We see higher rates of the BRCA mutations in those populations. And we also, particularly with Black women, outside of socioeconomic class, we see more advanced and aggressive disease. So we know that is a risk factor that requires some tailored screening recommendations.
Okay, and then obviously, if you've had a period or having periods, along with estrogen and having all the hormonal exposure, that's going to put you at, have risk of having breast cancer.
Right.
You hear about dense breast tissue.
Right.
First of all, what does that mean? What does dense breast tissue mean, and does that change your risk?
Sure. And so there are a couple more that are non-modifiable. So as you mentioned, having a menstrual cycle, if you start your menstrual cycle early, typically before the age of 12 is where it puts you at that extra risk. If you go into menopause late, if you've had radiation to your chest for lymphoma or some other form of cancer. And then, so dense breast tissue, the big question mark. So dense breast tissue is, I think, a really poor term for what really is meant to be a proportion. It is a ratio of the amount of fibroglandular or normal breast tissue to the amount of fat inside our breast. Every woman, no matter her weight or size, has both of those things inside the breast, and it's just a matter of how much. So women with more tissue and less fat tend to be overall a petite body frame and slender, tend to be, but not always, are premenopausal. We do know that up to 50% of postmenopausal women, despite that lack of estrogen and progesterone in their body, do maintain that increased breast density. Women who are on hormone replacement therapy in their postmenopausal age also tend to have denser tissue. And then on the flip side, even though we do see on occasion fatty breast tissue, which is not a judgment, it's just a fact. There's fat inside the breast, is sometimes at higher BMI or in postmenopausal women. And now the reason that we report this, the reason this has become the hot button issue is because a mammogram is an x-ray of the breast. And on that x-ray, we see black and white. The fat is going to be black. The tissue is going to be white. And when we are looking for cancer on a mammogram, it's also going to be white. So a mammogram is already trying to find the needle in the haystack, and it gets that much harder when looking at a very white mammogram, which is what you see with denser breast tissues. So we inform women of this risk for two reasons. Again, they need to know that their mammogram can be decreased sensitivity, and they need to talk to their doctor about what, if any, other options exist for them. Having an overall risk calculation, taking into account all of their risk factors, can help them decide if they need to do any additional imaging like ultrasound or mammogram or MRI, sorry. And then also increased breast density does increase the risk for the development of breast cancer a small amount, independent of other risk factors.
Okay. And now let's talk about things that we can, or modifiable risk factors. What are some things we can control to help decrease our risk of developing breast cancer?
So our top two are going to be maintaining a healthy weight. The reason being, our fat cells, our normal fat cells, do produce small amounts of estrogen. And as many of the things that we've discussed have shown us, it's that exposure to hormones that can increase our breast cancer risk. So by virtue of decreasing the overall amount of fat or adipose tissue in the body, we are decreasing our risk for the development of breast cancer. And some studies have suggested that actually weight gained later in life can contribute even more to that risk. So there have been some studies that have said like weight gained after the age of 18 versus childhood obesity or that baby fat. So the other is eliminating or reducing our alcohol intake. So more than one alcoholic beverage per day has been shown to increase the development of breast cancer. And that's for a variety of reasons, one of which, again, is increasing that estrogen exposure. And so, again, even though there are some studies that say it might be good for your heart, everything in moderation. So one or less drinks per day is best when you're trying to decrease your overall breast cancer risk.
Yeah. And then you already mentioned radiation to the chest for whatever reason would also increase, or we need to know that it does place someone at increased risk for breast cancer.
And that's sorry.
No,
so that's not radiation from a mammogram. So that's high levels of radiation, like therapeutic radiation. Mammograms and their associated radiation are entirely safe.
So it's different levels, right? And then also and you can tell me if this stat is correct, but I saw that 60 to 70% of people with breast cancer have no connection to these risk factors at all. And then other people will have risk factors and never develop cancer. So, we know what we know, and then there's stuff that we don't know. So just because you may not have any risk factors doesn't mean you could just brush it off and say, my risk is low. You never know, right?
Exactly. So again, the top two are being female and aging. We know that the environment, sort of the nature versus nurture is going to play a role. 75% of those who are diagnosed with breast cancer have no family history, and only 5 to 15% of breast cancers have a genetic component. Now, some of that might be because we haven't discovered the associated gene, but truly it does mean that most breast cancers are spontaneous mutations, meaning that they happen just to that one woman at some point in her lifetime, as opposed to being something that she's inherited.
Right. And then there was another little thing I saw that these things do not cause breast cancer. First of all, breast cancer is not contagious. Just want to put that out there. It's not contagious.
Correct.
And what about wearing underwear bras, breast implants, deodorants, antiperspirants? You already mentioned mammograms. The radiation for mammogram is not going to cause that. Caffeine, plastic food serving items, microwave cell phones, do any of these things increase your risk of breast cancer?
So of the ones that you mentioned, plastic is going to be the only thing that could be of concern. So we've all heard, hopefully by now, of BPA, bisphosphenol A. That's just one type of the BPAs. And Dr. Laura Shaheen does a ton of great work on the endocrine disrupting abilities of this as to how it affects our fertility and reproductive health. And the studies, again, are not quite as good to demonstrate an exact causal link between the BPA found in plastics and breast cancer, but there are some suggestions that it could be particularly contributing to the increase in premenopausal breast cancer. And so of the things that you mentioned, that would be the only one that is still a question mark. But deodorant does not cause breast cancer. Underwire does not cause breast cancer. Caffeine can exacerbate breast pain, as can underwire, of course, but neither of those causes breast cancer. And soy is one that you didn't mention, but I like to talk about because there was some concern previously that the phytoestrogens, which means plant estrogens of soy, so that's tofu, soy burgers, anything like that, tempeh, there was concern that it would cause breast cancer because it was estrogen. But that has been disproven. So the whole concept of estrogen and progesterone increasing our risk for breast cancer is because our breast cells have little receptors that, if you think of like the COVID that we've all seen with the little spikes. So they all have spikes on them, and something needs to meet up with them. When that happens, things happen inside the breast cell that increase the potential for the development of a defect that will lead to breast cancer. And so phytoestrogens or plant estrogens actually compete with our body's own estrogen. And so they actually decrease our risk for the development of breast cancer because they block our body's own breast cancer estrogen receptors. So as opposed to increasing the risk, it actually is protective.
Okay. I didn't know that. I didn't know that. So I'm glad we talked about it. Okay. So let's talk about early detection. According to the American Cancer Society, when breast cancer is detected early and it's localized, the 5-year relative survival rate is around 99%. So early detection is important. Let's talk about what does early detection mean? When you're talking to a patient or talking to, here, and you're talking about the importance of early detection, what does early detection mean?
Right. So breast cancer most often starts inside the milk duct. So you'll hear people say, I have ductal carcinoma, I have invasive ductal carcinoma, I have intraductal. The milk ducts, the same ones that provide milk to a child during lactation, is the most common site for where breast cancer starts. And so when it starts, it's inside the milk duct. And if it's caught at that stage, that's considered stage 0 of breast cancer, or DCIS, ductal carcinoma in situ. Now, as you mentioned, it's a 99 to 100% survivability rate at 5 years. And it can, when caught early, mean a smaller surgery. So not just, increased survivability, but smaller surgery, better cosmesis, better treatment outcomes, less complications from a smaller surgery. Stage 1 is something that has broken just outside the milk duct, but is still an overall very small size. It's still inside the breast, and it's still relatively near that milk duct in which it started. And again, the same, good survivability and small surgery. And the other thing is DCIS and stage 1 most often do not require chemotherapy. If they go on to remain at that stage at the time of surgery, they don't require chemotherapy, which we know can be a really difficult treatment for many women and men to process. So being able to avoid chemotherapy avoids any of the and so again, it's not just the decreased mortality and increased survivability, it's the decreased morbidity. So any of the associated side effects, which might not, end your life, but they can significantly decrease your quality of life and lead to complications. And stage 2, 3, and 4 just are associated with increased size and then lymph node involvement and then overall body involvement or more distant sites of involvement.
Right. And so, and along with early detection, Let's talk about the role of self breast exam versus the role of a clinical breast exam and what the difference is between the two.
Right. So clinical breast exam is going to be the one that you're doing with your doctor or provider annually. We typically recommend that to start at 25 for average risk women. And then self breast exam is something that we recommend monthly, mid-cycle for all women to start again at 25. There's been a lot of controversy about both. The reason being, majority of the areas, both that are felt clinically as well as by women, are going to go on to be benign. That said, for women who have not started screening mammogram, either because they are average risk and below the age of 40, or because they are not high risk, or because they're high risk but still below their screening age, they can detect their own breast cancers. For a screening aged female, I am more likely to find something when it's less than the size of a pea, and they are more likely to find something when it's the size of a walnut. That's why we stress the importance of annual mammograms for women of screening age. But for, again, women who don't have, who are not of screening age, the self breast exam becomes important because it is a way to detect the infrequent but possible breast cancers that occur at that age. So the ways to decrease those false positives, where you're not running into your doctor every 2 minutes for something that you feel. Know you're normal. Get very familiar with what the normal is for your breast. Do your exam mid-cycle. So again, that's halfway. That's day 14 of a 28-day cycle. That is going to, again, decrease the hormonal influence on the breasts and hopefully decrease any false positive lumps and bumps. And then don't be looking for symmetry. That's a mistake that we make. One side of the, one breast is not like the other. One hand is not like the other. My eyes aren't, even symmetric. And that's fine. That's just the way the body is. And so, again, knowing your normal is more important than saying, well, I feel it here, but I don't feel it here. When we do feel something, I made a whole video on self breast exam. There are several other good ones out there. And it's important to take note of the location, of the size, and if the area is mobile. So if it's fixed, it will not roll as you roll your hand or as you drag your hand. If something is fixed, you can consider calling your doctor, relatively soon. But if an area is mobile, again, if it's rolling with your hand, I do recommend to my premenopausal women to take note of the size and the position, and then wait a week and feel it again and see if it's changed. And if it hasn't changed, wait another week, see if it's changed, etc. Up to but no longer than one full cycle. So that would be 4 weeks for a 28-day cycle. The reason I suggest that is because for majority of these, they will have resolved by that 1 month time. If it has not changed, or obviously if it's grown or is growing, call, see your doctor. You're going to need, mammogram and or ultrasound depending on your age and your risk factors.
Great. And let's talk about, you already touched on some of this, but we'll talk about some of the signs and symptoms. You talked about how the breast or nipple looks or feels. And obviously, we're not symmetric. Nipples are going to be varying from side to side. So knowing what your normal is extremely important. Anything you want to add to about how the breast and or the nipples look when you're looking for signs and symptoms of breast cancer?
So I recommend doing your self-exam in front of the mirror, and that way you're able to really visualize the changes. I know a lot of women do it in the shower, and that's not unreasonable, but I just really think laying eyes on the breasts and nipple and underarm in the mirror are important. Make sure you're going from the collarbone to below the breast, from the breastbone to the underarm. There's breast tissue in that entire area, even if it's not the quote unquote breast that you're putting inside the bra. You want to be looking for skin changes. So if there's any discoloration, redness, warmth, flakiness, patchy areas on the skin or nipple. If there's any drainage from the nipple. And now, some women, when they do their breast exam, they'll also squeeze their nipple to see if something comes out. That's not the kind of discharge we're talking about. I'm talking about discharge that comes out on its own. For most women, for many women of menstrual age, or reproductive age, or who have lactated at any point, if you squeeze the nipple, something's
going to come out.
Right. And that's just, whether it's colostrum, retained milk, etc., something might come out. So it's really if it comes out on its own. Particularly notable is if it's bloody nipple discharge. You always want to let your doctor know about nipple discharge, but if it's bloody nipple discharge, you want to call sooner rather than later. Again, looking for that fixed mass versus mobile, looking for underarm swelling, and a spot of focal breast pain that hurts all the time before you've even touched it, right? So if you're pressing and it hurts, I think anything will hurt if you press hard.
Yeah.
So we're talking about things that hurt independent of position or palpation.
Yeah. And Robert, you just spoke about it, breast pain. Breast pain usually isn't a sign of breast cancer, but let's talk a little bit more about breast pain. What are some of the causes of breast pain? And then when do we need to be worried?
Hormones are the top 3 causes of breast cancer. I mean, of breast pain. That's going to be fluctuating hormones when we're early in our reproductive age, fluctuating hormones when we're perimenopausal and going through menopause, fluctuating hormones because of pregnancy, lactation, changes in birth control. We see women with new pain and they're like, no, but I've never hurt like this before. But if you've had any reason to have had a recent change to your hormone status, it's, more than likely going to show up in the breasts or, as you know, in the ovaries. And the second most common is muscles and bones. So, some women, it can be just from active workouts because we do have the pectoralis musculature under there, as well as a lot of tendon insertions in the underarm region. But we also can get inflammation of the ribs and the rib cartilage. It's called costochondritis. And it's something that can happen for no reason or can happen after a viral illness, any kind of viral illness. And so, you could have a common cold and start having this weird pain to touch or pain with movement in the chest area. And oftentimes it's costochondritis. We say that if it hurts when you press, if it's relieved by something like ibuprofen and warm compress, it's most likely to be the muscles and bones and specifically something like costochondritis. And then for any woman above the age of 40, I always make sure, if they come into me with breast pain, I always say, make sure you talk to your doctor about your cardiac risk and have that workup, because women, I am not a cardiologist, but women have atypical presentations of cardiac events and chest pain. So sometimes they'll think it's
breast pain and it's chest pain.
Right. Or indigestion or something like that. So you want to make sure that you're having that workup. So those are going to be the most common causes. There are some women who have decreased levels of an essential fatty acid, and they have chronic breast pain, and that can be replenished by vitamin E or evening primrose oil. I do always tell my patients to discuss that with their primary care provider, because it does require good liver function to make sure that you're able to clear that properly.
Right. And then let's jump right into fibrocystic breast tissue. What is it? And I hear I was told I had fibrocystic breasts, and I've been told I had them too. What exactly does that mean, and how is that diagnosed?
So I truly think that that's a little bit of like a garbage can term, like, oh, you have cysts, or oh, you have pain there, or oh, you have something. So it is an actual pathologic term, but I think a lot of things just get kind of thrown into there, just for the sake of lumping them into something. So cysts in the breast are very common. They are fluid-filled areas. We can actually get anywhere in the body, the ones in the breast being related to hormones most often. And, women, again, who have kind of this hormonal or cyclic breast pain, for example, a lot of times they're told, oh, it's because of your fibrocystic breasts. That may very well be. But honestly, until I have done an ultrasound to show that you have cysts everywhere, or a mammogram to show you have cysts everywhere, or an MRI, or I've done a biopsy on an area of concern and it comes back fibrocystic tissue, it's not an accurate term. But that said, it is probably not, completely incorrect to say that a woman has fibrocystic breast tissue if there's someone with cysts and pain, but it's not actually the correct term until a biopsy has shown that, which is most often not necessary. The times that we're doing a biopsy and it's coming back fibrocystic breast tissue is if a woman had calcium deposits that were of concern or indeterminate on a mammogram. and then went on to be benign fibrocystic breast tissue. So fibrocystic breasts are not something of concern. They're not something that warrant intervention unless there's a concerning finding.
Good. Okay, so let's move on to, we already took the breast exam and how to do it. We talked about the clinical. Oh, we were just tricking right through this. So I just want to just talk about the basics of a mammogram. What is it? Who needs it? And when? And what are the potential reads? Like, what are some of the potential things when you do read a mammogram? What are some of the more common things that you could see? And then if someone gets the result in their my chart before the doc calls them and there's something weird there, when to be concerned?
Sure. So a mammogram is an x-ray of the breasts. Screening mammograms are done annually on asymptomatic women, starting at 40 for average risk women. So again, that's the 1 in 8. Women might need to start screening mammograms earlier if their family history, their personal history warrants it. And that's a discussion to be having with your doctor before the age of 30, typically, because if you're going to start it early, sometimes it does happen at that third decade. So that's a screening mammogram. Diagnostic mammograms are done for women who have symptoms, and that's a completely separate concept. The images are the same, the appointment is different, the workup is different. But a screening mammogram is an x-ray of the breast. It's most often going to be 2 views of each breast, more if the size or shape of your breast. They are going to be doing 1 view from top to bottom, 1 view from side to side, with you kind of draped over the machine so that the underarm tissue is included in that picture.
Sorry, guys. Hold on. Hopefully she'll join here in just a soon. Okay, we lost her. Hold on. She'll probably join back in. I think she has kind of a bad connection. We'll try again. So Dr. Malik, if you're on, I'm accepting you, but you're declining. Let's see. Like you're trying. There you are.
Hi again. I'm literally standing like as close to the door as possible, so maybe I can catch some signal from somewhere. But so
wait. Let me tell you where we left off. The last thing we heard you say was that the 2 views, 1 with the arm up over, so you could get the tissue under the arm.
Sure. So exactly. So on a mammogram, we are looking at the breast tissue and the underarm area. We are looking for asymmetries in the breast tissue. Like I said, the breasts are not alike, but we still look for areas that look different from other areas in the breast or look different from your prior mammograms. That's another reason why if you have mammograms anywhere, we always ask you to bring them to us so we can compare. We're looking for masses, for calcifications. And the reason we look for calcifications is because they can be an early sign of breast cancer. Calcium deposits can be in the breast for any number of reasons, most of which are benign. But again, we look at them to make sure they're not an early sign of breast cancer. And we have certain things that we look for when we're looking at those calcium deposits. We look at the skin line to look for any thickening. We look at the nipple to look for any tugging, pulling, inversion, or retraction. We look for lymph nodes. So for example, for women who got their COVID-19 vaccines and had a mammogram shortly thereafter, there was the whole issue previously of enlarged lymph nodes, which was a very normal thing to happen after getting a vaccine because lymph nodes are enlarged at times of infection, inflammation. But our concern was making sure it wasn't breast cancer. So those are some of the things that we're looking for on your screening mammogram. So if you get called back, a couple of things. Do not worry. If 1,000 women get a screening mammogram, 10% of them, so 100, will be called back for additional imaging. Only 20 of those will need a biopsy, and only 5 of them will go on to have breast cancer. It is extremely common to be called back from a screening mammogram. It doesn't mean you have breast cancer, and it also doesn't mean that we're bad at what we do. That's just the virtue of screening. It's the same as I have a video on my reel on my page about TSA screening, right? So a lot of us get our bags opened. It goes on to be nothing. My mom's aluminum foil wrapped food looks like, you know, something concerning, but it's not, right? And so, you know, we all get annoyed with it when we're waiting in security line, but none of us wants to be on a plane that has something concerning on it. And the same is for our breast, right? None of us wants that, you know, something to be awry. We want to be thorough, and that's our job as well. We just want to be as thorough as possible. So if you do get called back and you do end up needing a biopsy, again, your chances are still low for it being breast cancer. And that's just the virtue of screening.
Yeah. Okay. So, you know, if you get called back, a lot of times patients will get the results through their MyChart if they're hooked up with MyChart. Just message your physician. There's going to be a plan in place. Give them a day or two. I know you're going to worry, but feel free to call to get an answer sooner than later so that you won't worry. But of course, it's always going to happen on a Friday afternoon, right?
Right.
Always
Exactly.
on a Friday afternoon. So, you know, it just happens. You know, my sister has gotten called back. I have gotten called back, and it's just one of those things. But the chances are everything's going to be fine. But you do want to have more. A screening test is going to make you come back for more tests, because that means we're going to pick up more people that have breast cancer.
Right.
As opposed to the opposite. If our screening wasn't that good, you know, then we might be missing breast cancer. So we'd rather err on the side of caution, if that makes sense. And that's why, you know, there's going to be more positive screenings with the mammogram. Okay, let's jump into some myths and facts. Let's talk about myth or fact. Finding a lump in your breast means you have breast cancer. Fact or myth?
Myth. So as we referenced, a lot of the myths, a lot of the lumps that we might identify on our self-exam go on to be nothing. Most commonly, actually, they are just our normal breast tissue that fluctuates with the hormones that are in our body. Okay.
Fact or myth? Is dairy, milk linked to a higher risk of breast cancer?
So that's actually an in-between. Does dairy milk directly cause breast cancer? No, but high-fat diets have been linked to the development of breast cancer. Also, the consumption of processed meats, which of course is not dairy milk, but just to discuss how diets might impact our risk for the development of breast cancer. If you're drinking whole fat milk every single day and exceeding your fat recommended intake, those could be things to be contributing to breast cancer risk.
Okay. Fact or myth? Men or males or anyone with XY chromosomes, they don't get breast cancer.
So that is a myth. We do know that while it's a lower percentage, cisgender men can develop breast cancer. And of course, as I referenced earlier, transgender men and women who have had exposure to estrogen in their lifetime are at risk for the development of breast cancer.
Gotcha. Okay. Fact or myth? Is hair dye linked to a higher risk of breast cancer?
So that is a fact, and again, with some nuance. So there are certain kinds of, and I am not as good at naming the ones that there are, so it's definitely something to do your research on. But there are certain chemical dyes that can increase the risk for the development of breast cancer, and I think there are certain processing agents that are particularly commonly used in the Black population that can increase the risk for the development of breast cancer. So definitely something to do your research on. I have posted on it before, and there are a lot of great Black female women's health physicians on IG who are posting that kind of information as well. One that comes to mind is one of my colleagues actually in my practice, Minority Breast Report.
Minority Breast Report. Okay.
Has posted on this before. So not to call her out,
I'll try to find it. Yeah, I'll try to find it and I'll add it into my stories. Okay. Fact or myth? A mammogram can cause breast cancer to spread.
That is a myth. So mammograms do not cause breast cancer. Breast biopsies will not cause cancer to spread. different cancer spread in different ways. And the way that breast cancer spreads is not through direct extension like that. There are some cancers, though, where that could be of concern, and that's something to talk to your doctor about.
Okay. Fact or myth, can breastfeeding reduce the risk of breast cancer?
That is a fact. So 6 months of breastfeeding, whether it's consecutive or over the course of multiple pregnancies, can decrease risk for the development of breast cancer. It's not going to eliminate it because, again, female and aging, top 2 risks. And something that we actually didn't touch on, never being pregnant or pregnancies after 30 can increase the risk for the development of breast cancer, whereas pregnancies before the age of 30 can decrease your risk for the development of breast cancer. And again, it all has to do with estrogen and progesterone exposure.
Right. Exposure, yeah. Fact or myth, if you have a family history of breast cancer, you are likely to develop it too.
So that goes either way. And again, it becomes what kind of family history. So family history of postmenopausal breast cancer in a distant relative is not going to impact your risk. You want to be looking at the age. So if it's premenopausal breast cancer, and is it a first degree relative or multiple relatives on one side, or male breast cancer? A family history of male breast cancer is going to put you at higher risk if it's in the first or second degree. It's always really important to know your family history, and not just of breast cancer. It's important to know family history of breast, ovarian, colon, pancreatic cancers, as well as melanoma and prostate. Not all prostate cancer, not all of any of those cancers are going to put you at risk, but if you start having enough on the same side of your family, you might want to talk to a genetic counselor to consider testing.
That's why whenever the doctors ask us all that family history, we get all irritated because we have to go through this whole list. That's why they're asking, because there is something to it. And I admit it, I get aggravated too. I'm like, oh God, I have to do this. But
nothing has changed.
I mean, we got to do it. We got to know our family history. Okay, fact or myth.
Yeah, and update it every year, because it's amazing how you'll go year to year and be like, no, you're low risk, you don't need genetic testing. And it just takes that one change for your doctor to say, hey, you know what, you need it. And it could be positive. I've seen it happen so many times.
Okay. Does smoking cause breast cancer? Fact or myth?
Smoking can increase the development. It's not nearly the causation as with lung cancer, for example, but it is a risk factor for the development of breast cancer, much in the same way that alcohol is. It has overall carcinogenic effects.
Okay. And we already talked about antiperspirants and deodorants. They do not cause breast cancer. Let me get you some more real quick questions. I'm going to ask you like 3 more questions. Let me pick the ones. Is there a link between oral contraceptive use or hormone replacement therapy and breast cancer?
So again, because there's hormone exposure, there is an association and an increased risk, but the overall increase of risk is small. And both hormone replacement therapy and oral contraceptives have a lot of uses that are beneficial to women. So this is a very nuanced conversation. I do not, throw either one into the, risk category strongly. I think, again, oral contraceptives can decrease our risk for the development of ovarian cancer, which is something really important, especially since ovarian cancer has no real way to be screened. And hormone replacement therapy can be, cardioprotective, protecting bones, et cetera. So I think that's a discussion to be had with your doctor. Discuss reasons you might want to be on it, why you might not want to be on it, and go from there.
Yeah, and I'm 48. I'm on OCPs, and I went through the risk-benefit analysis with my OBGYN. I won't go to the reason why I am, but we decided as a team that was because of what I needed treatment for. That's what I was going to do. But, it was something to consider in my age group, right? So I'm 48. Being on hormonal contraceptive or oral contraceptives is not typically recommended, but given everything, that's the decision we made. So you go, having that decision and that discussion is key with the person that knows you the best, your general OBGYN or primary care physician. Okay. I'm going to give you 3 more minutes. I just want you to, and I had more, maybe we could do this on another time. Give us, and I don't want to look over it, and we talked a little bit about it, but male breast cancer.
Sure.
Tell us what some important things we need to know, because males do develop breast cancer. It's obvious, you've mentioned it several times, the importance of knowing about having a family history of male breast cancer. What do we need to know?
So men can look for the same things that women do. Of course, self-exam isn't necessarily part of their monthly to-do list. unless there has been that estrogen exposure as a transgender male or female. But otherwise, it's just looking for lumps, pains, changes to the nipple, changes to the skin, changes to the underarm. And if you identify those symptoms, you know, tell your doctor. I know a lot of men, you know, it feels like a taboo. It feels, you know, not that I feel this way, but some feel that it's emasculating to even be talking to a doctor about their, you know, their chest or their breast. But they can get breast cancer, and it's really important to talk about those things. Many of the lumps or areas of pain that men feel will go on to be benign male breast tissue called gynecomastia, and that can form for a variety of reasons. And even though that's benign, it's actually really important to identify, because sometimes it can be related to medications. It can be related to hormone imbalances. For cases, it can actually be related to a hormone secreting tumor in the testicles. And so I'm not saying this to scare any men, but that's why it is just as important for men to be paying attention to their chest and breast area, because they can get breast cancer, and it could be related to something else in their body. As in terms of male breast cancer, so the reason that it puts their female relatives at risk is because male breast cancer is often associated with a genetic mutation. So we know men can have the same types of genetic mutations that women do, notably BRCA1 and 2. So Anitha K. Patel, MD, she's a huge account on here, and has been open about the fact that her sister-in-law was diagnosed with ovarian cancer, and her husband went on to be diagnosed with it as well. Not ovarian cancer so much as the associated mutation. Yeah, the BRCA mutation. And so, and men can pass that on then to their offspring, male and female. So it's just, it's really important for men to pay attention to that area as well.
Yeah, so that's all I have for you. I know you're going to have a busy day. Thank you so much. I think this was very informative. If you guys have any questions, you can drop them in the comments under this video on my feed. And whenever Dr. Malik has some time, she'll go through and answer those questions. But I'm sure we're going to get together soon. Thank you so much. I know it's busy, and I really appreciate the work that you're doing. So thank you so much, and I hope you have a great rest of your week.
Thank you for having me, and same to you. Thanks for everything.
Where do we find you on Instagram?
So at Anjali Malik MD on Instagram, Twitter, TikTok. Although I am nothing like our friend here. You have an amazing account both here and on TikTok.
Thank you.
Thank you. Small account. That's also my website and Clubhouse. So at Anjali Malik MD everywhere. And
then tell me real quick again. Remind me what the name of your colleague's account was.
Minority Breast Report. I know that she's done a post on
the hair
beauty products in the black community.
Beautiful. Yeah. So yes, I will post that too in my stories. Thank you so much. Have a great rest of your day.
You're welcome. Thank you.
Bye bye.